Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and today I'm with Jessica and Florian. How are you guys doing today?
Good, thank you.
Very good. Thanks for having us.
Hey, well, I definitely appreciate you jumping on. You did a presentation at SOMA, and I was really interested in getting out, being able to hear it because there's so many things going on at SOMA, but also being able to deep dive into the ins and outs of operations in Ukraine. But before we kick off, Jessica and Florian, would you guys mind doing a quick introduction of yourselves?
Yeah, absolutely. And thanks again for the invitation to come on, Dennis. We really appreciate it. It's an honor. Obviously, we think this is a pretty important topic, so always happy to deep dive. I'm Jessica Patterson. I'm an emergency medicine physician by training in the civilian world. I've worked at a large trauma center in Philadelphia for most of my career at Temple. Have been significantly involved in projects in Ukraine since 2022 and the beginning of the large-scale invasion. Currently working with our own NGO, Ethos Solutions. And that's kind of my background. I'll let Florian.
Yeah, echoing what Jess said, thanks for having us. My background is way back when in the Austrian military as a medic. I'm now an ER doctor, University of Michigan. Still involved as a civilian with many different projects, mostly now focused on Ukraine. I'm the medical director of the SOCM program in Flint, Michigan, and medical director of the Genesee County Sheriff's Department, who in part trains the SOCMs here with us. That's my connection here. Been involved, same as Jess, in conflict medicine for many, many years now, all over the world. I won't list all the countries, but Ukraine is our, unfortunately, most recent focus over the last few years. So thanks for having us.
No, I absolutely appreciate you guys willing to come on. And definitely the topic, clinical practice guidelines, performance in large-scale operations, just from the perspective from Ukraine. There's a lot to get into because large-scale LSCO is super hot topic, and it's just like the name implies, incredibly massive, and not a lot of people have done it. And then you throw in, clinical guideline performance in the middle of that. One, why did you pick this? And two, how on earth did you even collect the data to come up to a conclusion?
Well, it's a great question. I think the experience we've had on the ground there is sort of what informed this. So from everything from seeing with our own eyes, visiting different settings with casualties, and spending a lot of time talking to the people doing the work there. So the doctors, the medics, the soldiers on the front line, hearing their perspective. And something we've heard over and over again is this isn't GWOT, this isn't Iraq, this isn't Afghanistan. And having the understanding that these clinical practice guidelines are CPGs from our own DoD were really evolved and came to age in that era of GWOT and were refined and honed and performed excellently. And that kind of begs the question, how will these same guidelines perform when they are utilized by a totally different system, a different ground truth, with some major differences? And we wanted to really actually start to gather some data to get those answers, because not only is it critically important to feed back to Ukraine and their efforts, heroic efforts in the war there, but also looking ahead and saying we need to learn these lessons now and not wait until it's too late for the next conflict as well. So that was sort of the decision. And then how to gather the data, it's a tricky one. I'll let our research expert over there, Dr. Florian, take that one.
Yeah, sure. I mean, as Jess said, basically the idea really came from us. We've been on the ground since week 2 of the conflict in various durations. So we've seen pretty much every phase of the conflict and how it's evolved. And one thing for us was clear: we need to gather some data to both share it with our allies, but also keep it for the Joint Trauma System, which we've been working with on this. And we are funded by the DoD as well to do this project, because it's such a key thing in how to actually get the data out of there to see how we can adjust things. So the way we collect data is it's qualitative research. There's some quantitative data we're getting, but really what we're looking at is mostly high quality surveys. And we got some slides also. We'll go over some of this in much nerdier detail, but really the big overview is we only talk to people that we know do reliable work in country. We don't just send out surveys and like, hey, have you heard of somebody? Does your hairdresser think they spent some time in Ukraine? That is not how we gather our data. Like every single response we have on our surveys is validated. Somebody that we or one of our operational partners knows extremely well and is actively providing care instruction in country. So what we do is we basically send out surveys they're not just sent out via email. They're like taken in person by our colleagues who are doing operational work and are actually filled in real time with a lot of free text ability to give us feedback on that. I can elaborate on that, but that's the very big picture is what elements of CPGs are being followed and what are the barriers. Because I think that's the most important and pertinent stuff to bring back to JTS. Be like, hey, here are the things that work and don't work in a LSCO environment, at least in that one.
Yeah, absolutely. I think probably the best thing we can do is just jump into the presentation.
All right.
Good.
Let me know if you can see the slide.
I see
Perfect.
All right, thanks, Florian. So as Florian mentioned, this work is done under a global health research initiative grant from the DoD, focused on these medical best practices in near-peer conflict. So that's the overall mission of the work we're doing specifically for this research project. So we kind of got into this question of why, and expanding on that a little bit, the sort of first issue that we saw in country, which was really the inception of this project, was the prolonged tourniquet times, which I think is now part of a wider conversation, which is fantastic to see that people are really talking about this. But early on, for 2022 and 2023, we were seeing a lot of these complications that just didn't match up with the numbers that we knew came out of the GWOT era. So amputations, renal failure from prolonged tourniquet times, and from talking to those people doing the work, we were getting these stories that just seemed, almost unbelievable to hear of these tourniquets being on 16, 20 hours and trying to piece together, well, how could this happen? In TCCC, we know XYZ. And so the first output of this was a case study that we published. We wrote this in mid-2023, published it in JSOM, working with Ukrainian colleagues, which is always important in any work we do here, and kind of breaking apart, I think, 8 or 9 cases, what happened the best we could decipher from point of injury to their outcomes, which is a really difficult thing to do in Ukraine. And it's one of the reasons we are gathering survey data instead of casualty data, because getting reliable casualty data for a large number of patients is just a really difficult thing to do there for both operational security, of course, but also just the medical record system there is incredibly different. Their system is so heterogeneous and fragmented, and there's no real consistent tracking that can happen of casualties. And so we started off with a case series to kind of learn some lessons and try to understand some common threads. The biggest one probably being the prolonged evacuation times, just leading to these tourniquet issues. And then we want to take the next step and say, well, we need to understand more about this, and we need to structure a project to try to get the best data we can. And that survey data is a proxy for the casualty data, which would be the ideal. But I think especially when you're gathering data in a conflict zone, perfect is the enemy of the good. And so we needed to go with what was more feasible. And that's how we came about to the surveys. And how we actually gather this data, as we already mentioned, we work with trusted partners. So people or organizations who are doing work in country we believe in and are happy to support and work with them. And a quid pro quo method. So we're asking for really important information from our Ukrainian allies, and we need to give something back. It's just the ethical thing to do. So we kind of just ask, what do you need? That's augmenting training resources, supplies. We basically just try to meet them with what they need. As Florian mentioned, we're not doing mass distributions. This is going through our trusted partners to try to make sure actual subject matter experts who have the most knowledge of anybody in the world about what's happening at the front line are filling out our surveys.
All right, so I can talk a little bit about how we kind of decided on what to actually study, because there's a ton of CPGs, as most of you know. I'll just briefly let this flash on the screen. Some of the folks that were influential in actually selecting the criteria for CPGs to study, and we had an expert consensus on what to be focused on, because there's too much to study, and our surveys are 100 questions long, and we obviously have limited time and limited power for the folks to fill this out. So we basically pre-selected some of the CPGs that have the, by expert consensus, highest value for actual study, and these should not be surprising to anybody who's at all involved in the field. Blood transfusion is an obvious one. Damage control resuscitation, and also prolonged field care was a clear, highly sought after topic for us to study. Analgesia and sedation, also important and kind of fits the same topic. And prolonged casualty care and T-TRIC obviously was selected as well. This is also not very surprising. This is more for a fun fact. These were the least important topics to study, so we're not going to study much drowning management. Sorry, we're not taking any lessons from drowning management and scorpion stings from Ukraine. Apologies to those who were hoping for some hot facts on that. This is the promised nerdy slide on how we actually select our lessons learned and everything else. Because in the end, we're basically providing a gap analysis. Very broadly, we selected the CPGs, the clinical practice guidelines, had an expert consensus that developed our surveys. It has focused predominantly on damage control resuscitation at this point, that are taken back to subject matter experts with combined hundreds of years of experience in conflict regions. And basically both feeding back information, but also summarizing it for JTS to as a lessons learned document as well. Again, feel free to interrupt. I don't want to just run through these, but I'll very briefly give some key statistics on our respondents. This is from SOMA, and I think we have like maybe quadrupled our numbers by now in high quality responses. You can kind of see the years of experience, and it's a bit of a snapshot of what we actually see who the medical providers in country are, right? I mean, look at that 0 to 5 number. That's a crazy amount. Meaning, we obviously ask them free text questions as well, and a lot of it is fresh medics, fresh folks being straight out of medic, being thrown into conflict. I mean, they're learning fast, but a lot of people have no civilian experience before joining up and being in a provider role, which is interesting.
Yeah, I think it's very reflective of just the attrition of their
100%
guys in the field.
100%, and I mean, Jess and I have seen a lot of cases where specifically medical providers are being targeted, which certainly doesn't help these numbers and the experience that is lost. And again, this is something why we're pushing so hard for, like, we're not pragmatic. We're not dogmatic about CPGs. We're not saying you got to follow the letter of the law. We're very much like here's some of the best practices, and let's figure out how to like achieve them even in adverse environments, even when you have a scarcity of resources and so on. So we're very much reasonable about this and pragmatic about it, because if you're a fresh medic, fresh out of school, fresh out of training, and are being thrown to a casualty collection point, if you're a stabilization point, at that point, you need something to guide yourself on. Yeah. Broadly, distribution, we try to have a pretty decent distribution of folks, because we're looking at all roles of care. So we're really, our focus is predominantly role 1, role 2, so really forward. We're also asking combatants without specialized training. We're also asking physicians. There are some physicians who are close to the front lines providing care, and getting a broad sampling. So it's a pretty good distribution here to actually get this. And this is obviously tailor-made slide for Soma. There we do have a by now way more soft trained respondents in our survey. And then again, we're very much focusing on role one. This graph has kind of stayed stable since we started this process, and we really have a pretty far forward look more than anything else, because I'm guessing you would agree that that's where the most acute and most need is for excellent care in the initial stabilization phase.
Yeah, absolutely. Especially when you're talking about extended care, but if you suck at T-TRIC or that initial contact with the patient, like, you don't have to worry about any of the other stuff afterwards, because they won't make it.
100%. And you can kind of see here, I mean, this is not a perfect sampling, right? I mean, this is basically who our partners and us trained, who we had access to. But we do pride ourselves in being very selective in terms of trying to get a very good distribution of folks. And like, the field setting is certainly a very, very, as opposed to a hospital setting, is very much like a key point. Similar to the evacuation setting, transporting patients back. All right, so that's the broad overview. If you don't mind, we have a few slides on like one of these samples we picked out of the damage control resuscitation CPG, and like showing off some of the stats on blood administration. That may be interesting as a bit of an overview of one of the key lessons we have from what we're finding, and a little interesting point. So this is the distribution, and at Soma we actually saw some great talks of the very high end of the medical spectrum, and we have the utmost respect for our Ukrainian colleagues who really do a ton with very little, and it's fascinating to see some of the high end stuff, ranging from walk-in blood banks to Reboa. Some have ECMO capabilities in their relatively forward places. I mean, it's some fascinating stuff that happens in country, but the reality is we have a pretty good sampling here in terms of the administration of blood, and it shows a bit more of a realistic picture in terms of not the tip of the spear of what's possible in medical operations in LSCO, but also the reality of what actually is done. So the top graph here kind of shows you the blood administration frequency in a role one setting, meaning highly conflicted regions with lots of casualties, and 42% not available. Yes, this data is a year old now, so I'm hoping it's changed. Little preview, it's changed some, but not to the extent that now we're at like 10%. And that's kind of rough, right? I mean, the other thing I want to point out and discuss maybe a little bit is that not practical category. We also asked some questions, and I'm like, hey, why is it not practical? Because it doesn't really help you just have that number. And a lot of it is through denied airspace, denied resupply, and prolonged care being necessary, which is very rough.
Yeah, so just, I guess, ask a follow-up with that. So not practical, like they had blood and decided not to use it?
It's the majority of them it's not practical to even have the capability to provide blood in that setting. And that's the few answers we had gotten on this was, so we allow people to have like some free text with it. And we do some interviews now and do more qualitative things, that we can't have a reliable cool chain in the summer. We can't have, we basically can't get resupply. It's a logistical problem. We both can't get our people out, and we can't get blood supply forward. They have a pretty robust network of being able to get casualties with autonomous vehicles, drones. It's pretty impressive what they can do, but the reality is on a huge front, as you all know, the availability to actually deliver blood and keep it cold, and then blood warmers and everything else is very limited.
Yeah.
And then you can kind of see how this changes as you go further backwards. And obviously in a role 3, there's certainly a lot more blood available. And so we kind of thought, like, shoot, what do we feed back? Like, what is the reason for this? Just telling that story isn't very exciting. It just tells you something everybody knows. If I have to convince anyone on this podcast that, blood transfusion in the pre-hospital setting is important, then we've kind of failed already. But it's more about, why is it not being possible? And we kind of saw a few different things. So a lot of them have training, right? I mean, look at this fantastic thing here. Not trained is 2%, right? It's a couple people. Everybody else has either performed it, has life tissue training, some training. So it doesn't seem to be training. Like, people get the training. I mean, our operational partners, we ourselves have been there, done a ton of training on blood administration. There was some that we kind of were able to suss out, like, okay, is it maybe a protocol issue? And we've definitely noticed, I mean, this is crazy, right? Like 32% required a physician that's at the lowest level allowed to perform blood administration. That is something that needs to change, right? I mean, that's certainly not a reasonable level or qualifications when you have folks being able to do so. That's certainly something we've been feeding back in terms of, hey, let your maybe don't restrict it to the physician level. You really, right? I mean,
that's a European thing as well. It's not like an only Ukraine problem. Like, there's a lot of, every country, period, has their own thoughts on who can do what in medicine. But yeah, that's not just a Ukrainian problem. That's a European problem, largely, I think.
100%. I think you're right. And it's also like something that hasn't adjusted out of necessity in some places, but has in other places. We saw a lot of heterogeneity in what actually happens in different parts of the country. So it really boils down to like local protocols and like state protocols and so on in country. And it's a lesson learned, certainly for our NATO partners, to like think about readjusting your protocols if they're as restrictive as they are in some places there. And then we asked about barriers, and this kind of goes back to your initial question, like lack of training, not that exciting. Tactical considerations, certainly. A lot of concerns about adverse reactions and supply issues just being a huge problem. And this has kind of shifted more towards the supply issue thing as well. And then looking at it, like we basically asked, you could select more of them. Logistical challenges, 3 out of 4 of those providers said yes. 50% had a lack of equipment. Only 30% said, we could use some more training. There's a lot of concern about disease transmission, which is not unfounded, but it's certainly something that can be overcome with proper logistics, transfusion reactions, and legal and ethical concerns. I mean, 22% of legal concerns in an active conflict zone is kind of wild to me, right?
I think any provider, period, when you don't want to say we don't have enough training or I don't know how to do it, you hide behind legal concerns or diseases or things like that. It's just, I think a lot of it is just a lack of knowledge. Would you rather have a dead guy or not?
That's a good point. That is very much a good point. And then a couple more slides. I promise the boring part is over in a second here. But we basically said about half of them use whole blood, which we appreciated, and we did see that it's not really restrictive criteria, but some of them kind of did have some really restrictive criteria. So they basically said, well, you need to have, the easy one is shock, right? If somebody's in shock, they get blood. Perfect. That's reasonable. I think all of us can agree with that. Some places actually have multiple amputations as a criterion for meeting blood transfusion criteria. And I think many people on this who are listening to this right now have dealt with casualties with a single amputation who very much required blood transfusions, especially if not the bleeding wasn't controlled immediately, or if there's other injuries as well. So this is certainly something that kind of stood out to us in terms of, well, that's a restrictive criteria, and it goes back again to like the availability of blood, right? I mean, we're really looking at a necessity of whoever wrote that protocol probably realizes that early blood would be better for more patients, but you probably can't be as generous if you have an extremely limited resource.
Yeah, I think just obviously I have no idea who wrote that, right? But it looks to me like you're trying to make a triage decision easier for the people under you when because I see it all the time with medics. Like, I'm going to hold on to this because the next patient we get might need it. That's not triage. You're just hoarding gear. You treat the guy in front of you that you know you're going to, that you have. And when more patients come in, then we make more triage decisions of whether we continue doing what we've been doing or do we shift fire on our treatment plan. But that would be my guess, is when you have very restrictive protocols, is the heart's in the right place of trying to make triage easier, but you're just not treating people like they should.
I think I agree with you. Basically, there is a difficulty in terms of like balancing this, right? I mean, ideally you'd have like adaptive protocols where you're like, if more patients show up, if you have fewer patients based on your availability, because one size does not fit all. I'm kind of worried, right? Like, you have these guys fresh out of medic school, and if you don't give them like strict criteria, I don't know. I don't have a good idea on how to fix this, right? Because like you got to give them criteria, because otherwise the moral injury of like you having to decide and then you hold off and then no casualty shows up and you feel like, I might have saved this guy if I would have
Just
given
to
more
jump in
blood.
for a quick
Yeah.
second, Florian, I think this gets, Dennis, what you're bringing up gets into like one of the really big root factors that we're trying to understand better. And I think a trend towards really rigid protocolization, which is something that already existed in Ukrainian medicine. That's like the way their medical system, and it can be regional, city by city. Different oblasts will have different protocols that are literally like Ministry of Health laws. And so the fear of making a mistake is pretty significant. The culture that we have in the American or Western medical system of like, we do morbidity, mortalities, we try to look at the system's error rather than point fingers at the individual. I think that is not a concept that is universally embraced, for better or for worse. It's just different approaches. But I think something we've seen, and I do not think this is specific to Ukraine at all, because I've seen it doing training in America too with highly specialized medics. When they're very fixated on a protocol, the fear of getting it wrong can kind of supersede that just looking at the patient in front of you and trying to use your making a judgment call. I think, I do think that factors in here with a trend towards protocols getting more and more rigid and maybe moving away from the empowerment of the provider to make a decision, just to throw that out there.
Like, I could easily see, like, had I see more about his protocol other than multiple amputations. It's, the medics receiving and doing the initial intake of the patient, unless he has multiple amputations, like, don't give blood. However, 5 minutes later, when the provider gets around to him, he instantly says, no, this guy gets blood. I could easily see that, where you have essentially multiple levels of guidelines. Each more, as you go down, it gets more and more restrictive, and that's almost universal around the world that I've seen.
100%. And honestly, this conversation is great for us, since we're going back all the time and having more qualitative research in terms of asking follow-up questions about this, because the idea is to come back with like these exact answers and some suggestions for solutions. Going on, we're almost done here with this. Basically, we do see a decent amount of walking blood banks. Stayed fairly stable in last year of data gathering. Would have liked to see more. We've definitely helped implement some of those. And decision makers, this goes back to your point, Dennis, here, who decides if a patient gets, in this case, packed red blood cells, but also whole blood, and it's physicians in the most case. I do caution that like the availability of physicians at stabilization points, casualty collection points, whatever you want to call them, is much higher than in what we'd be used to. So it's a little bit less of an issue of availability of qualified personnel in that case. They are great about, so this goes back to like really important stuff. Like once you start giving blood, you give calcium, great compliance with that. People actually follow those key points from the CPGs. When you stop giving blood products, does not seem to be a very good consensus on this. I mean, that pie chart's pretty equal pieces, right? Turns out nobody has a good clue on that. Maybe we should standardize. Maybe one of these slices of pie is correct. I don't know. I don't have the answer.
Yeah, I think I guess leaning on a previous podcast with Max Shurkin, we were talking about shock in itself and just deciding when to pull the trigger on giving blood. And it's actually quite a bit harder than what the protocol lays out, because the protocol says, hey, when their systolic blood pressure is 100, and below, go ahead and give it. Well, that could be like a really short time period between somebody's, with altered mental status, but a normal intensive, and then they crash. Like that can be a real short window, because you're dealing with young, healthy people who can compensate like champions.
100%. We've all seen it, right? Like the healthy young patient who does great until they don't. No, I like that conversation, because I don't think we truly know, and I think we're actually lacking the measurement tools to do so. And for better or for worse, we don't have the hard data on this. I mean, this is obviously a call for as much data gathering for these patients in Ukraine, because nowhere else do we have this amount of casualties where we can learn from what works and what doesn't. Yeah. And then again, calcium administration after a certain number of PRVCs. So things are very heterogeneous. I'll hand it over to Jess for some of those lessons we have.
Thanks, Florian. Sorry, my internet connection's a little unstable here, so hopefully that holds. But so what are we doing with this data? So I think, we've kind of presented some raw data that by itself requires a lot of like reading between the lines and trying making assumptions. I see this, we're kind of working in a pyramid of data. That's sort of our foundation. So a good amount of raw data, and that lets us start asking the right questions and getting to the more specialized level of seeing these trends, or seeing these surprising or not surprising results, and trying to get to what is driving those. And so in addition to more targeted surveys, we're also rolling out our TRIC and our DCS surveys at the moment. We're starting to do in-country interviews, like going to the places where we can sit down, talk with some of these subject matter experts doing the work, and kind of walk through these questions in a more nuanced way. Again, it's research with a lot of biases inherently, and we have to navigate that as we go. But we're doing the best we can to get some good information. Some of the trends and barriers, obviously resource constraints is a big one. And it's really variable. So by region, down to like brigade unit level, it can really vary. So what the equivalent of a role 1, role 2 in this area with this oblast might really vary from another region. So that certainly creates a barrier to universal adaptation of these guidelines. And some are just lacking comprehensive medical supplies, like reliable tourniquets, some of the really basic stuff that is like critically important. And I do think that becomes an important part of the conversation when you are talking about some of these really advanced capabilities that some of the units are looking at and excelling in, things like Roboa, the sort of sexy stuff that people want to talk about. But the real meat is obviously the basic supplies and things like tourniquets, and would try to ensure that reliable tourniquets are on every soldier is obviously a priority. And then operational, obviously the ground troops in this war are pretty intense. The relentless drone fire are universally reported as a barrier to particularly the prolonged care field. I'm just feeling like you're never off the X is something we kind of hear from a lot of the people we talk to. And that just concept is really difficult to apply to the reality in front of them. And then the environmental, obviously the prolonged evacuation times is probably the most important factor to certainly release the tourniquet issues and a lot of the other ones we see as well. And then restrictions from command. Obviously, this is an argument you can make in any system, but a disconnect sometimes between the high up levels, what the priorities are, what the policy should be, and then what the troops actually doing the work are seeing and struggling with. One of the things that we really try to do is like give a big voice to those people who are on the front line and trying to bring back some of those lessons and kind of shout it into the people who might be able to make some decisions. So those are some of the overall barriers. The next slide, Florian.
Yeah, and that especially like the tactical ones, like that's obvious. That's obvious. Like there really is no real safe place to be because you're under either artillery fire or just constant drone swarms around. So that definitely puts a damper on your treatment protocol. But definitely like the bureaucracies, we're dealing with a completely different culture than what we're used to. Like obviously their cultures are at least somewhat based on, Eastern European ideas of things, and an American or the West trying to influence that has its own challenges, because you're dealing with different motivations and education levels and things like that.
Yeah, absolutely. You had a Ukrainian physician on a few months ago, Dr. Katerina, who I thought just did an exceptional job of, obviously her perspective is more important than all of us when it comes to this, but talking about just the training of a doctor is so variable from doctor to doctor. There's no implied assumption that we all get the same training there, and it's actually quite different, and they have to fight for different trainings, and even those little things influence the perception of a guideline and how to implement it and how to. It seems simple, but it's so complicated, and I think there was a collective naivete of probably all of us, who wanted to provide these guidelines and think like, well, all you need are these guidelines, and then morbidity, mortality will reflect our GWOT era. And I think that it's clearly just a lack of understanding of some of the ground truths, and we're trying to catch up now and hopefully do a better job as an international community of understanding the realities that they're dealing with and how it does really influence these guideline implementations. But yeah, cultural is huge.
Yeah, absolutely.
And even the language, it's not even just, even translating our surveys to make sure that they are universally understood has been pretty challenging because the medical terms, there's often not equivalent. So even translating a guideline, sometimes there's not an exact translation, and a lot is left up to interpretation. A lot of people were Russian speaking up until, understandably, that was sort of abandoned a couple years ago. And that those little misunderstandings or the nuances to accurately translate a guideline can have huge implications. And that's another sort of unique challenge that I think was probably not fully understood. And that's another thing we're sort of navigating at our own level. So on a huge level, obviously an issue. And then, as we've talked about, some of the systematic barriers, I think a really interesting example that we touched upon in our tourniquet paper was at one point, because they were directly translating a line in the T-TRIC guideline, a protocol piece said that only a medic or higher could take off a tourniquet. And that actually becomes like a legal byline. And then all the medics were pulled off the front line for many reasons, or at least a majority were pulled off. And then we're in a situation where these service members were doing what they've been trained to do, put a tourniquet on, and then sitting there for these prolonged evacuation times, not being empowered to take them off and actually fearing that they were doing something really bad or wrong. And I think it's so important to understand that even for highly trained doctors, like the mental act of taking off a tourniquet requires a lot of understanding and empowerment to do that. And it really shouldn't be taken lightly. And certainly when you add in a fear of, well, I'm actually breaking a law, that's hard for us to understand. I think just as a barrier that was amended partially because of these conversations happening. So fortunately, that was one correction that was made last year, which was good to see. But yeah, so variable.
That's a definitely the fear of punishment is definitely way different in Eastern Europe than it is here in the U.S. Like you get made fun of, there you go to a gulag, so you can definitely understand.
Yeah, and I think we can't just assume that, the answer isn't that, well, Ukraine just needs to change. And it's like, obviously every culture has its pros and cons, but just understanding the reality that, you know, how mistakes are viewed, especially in medical practice in conflict, is different. And that even accurately reporting some of these complications, were a joint trauma registry to exist, which I think is a really challenging thing to expect this country in this moment in time to create. Obviously, it would be great if it did, but even if it did exist, will we have accurate reporting because of this? Because part of the whole spirit of that is to track the good and the bad outcomes and understand what's influencing them. So yeah, on many levels, it starts to get very complicated. All right, so wrapping up the slides here. So where does this leave us, as of SOMA? So just really important, obviously, to understand this isn't Iraq and Afghanistan, this isn't GWOT. The ground truths are just drastically different, and that reality of everyone's going to be in a hospital or higher level of care in 1 to 2 hours just doesn't exist there. The standardization of training is just doesn't exist. So the word medic can mean a different thing unit to unit. They have different levels of medics within units, and the training behind one medic versus another is not standardized, which also complicates guidelines and protocol implementation. And then, I think we've really learned, and also from implementing some of these lessons in training in the Western sphere, a lot of these problems are not nation specific. I think we should be asking ourselves, how would we do in this ground truth, and not make these assumptions that, well, that's Ukraine, it would be different. I think that's just a really dangerous mindset to have, and trying to understand where these barriers can be closed, and how do we translate that really low morbidity and mortality, like a all-time low in history, in conflict, like how we know the science behind it, we know the medicine. How do we encapsulate that and make sure that it's appropriately utilized in these different ground truths? And just a quick plug, we're an open book for data sharing and collaboration. So if people want more of our data, we don't hoard it. We'll share whatever we have with you, and are always open to collaborations or feedback, or wherever people want to email us, go for it.
No, well, thank you very much. I think what were we talking about? I guess if you, from the data you have right now, because this is such a difficult problem, because we're flying the plane and trying to update the plane at the same time. What would be the easiest win? I guess, would it be more training to the medics? Would it be throw more stuff at them? Or would it be actually trying to influence the culture? What would you think is the easier win?
It's a great question. I wish we had the answers. I think we can offer some ideas, and hopefully your specialized audience listening to here, we'd love to hear their ideas as well. I think probably a twofold solution. I think an investment and commitment across like all armed forces towards medical training is critical. And you hear that from a lot of the, Ukrainian physicians and people really working to implement this, and just sort of there's limited time, limited resources, and we hear a lot that medical training is what gets pulled to prioritize other training. And so obviously they have to weigh a lot of factors, but I think a commitment to understanding on multiple levels how important some standardization of training and refreshers and just ongoing access to that training is. And, even just is the right thing to do, but also, from combatants that have less recovery, get back in the fight sooner. And just from a also like, global perspective, there's many reasons why that's should be important. And then I think on a policy level, on that higher up level, we do need to be having more targeted conversations about, the risks of over protocolizing, or how do we weigh that with empowering providers to make common sense decisions and support them. I think that does come at a policy level. The medicine is the medicine, but the way people are empowered to utilize it comes at that level. So neither of those are simple, but I think those are probably the two approaches to just keep, there are people out there doing this work and just to keep at it. Florian, I don't know what you
No,
think.
I mean, shockingly, we're on the same page as usual. But frankly, I do have to say we have some really great pilots and really great ground control, or whoever else you want to call part of this discussion in your system here, basically in Ukraine, trying to do this all in a very, very challenging environment. The individuals we've worked with were incredibly impressed by, and they all tried to implement these things. There's obviously issues. I am amazed by their ability to repair the plane as they're flying it, and it's fantastic. If I had a wish list of things that's realistic, I'd probably also start with ensure a minimum training standard. And I'm not saying you need everybody trained up to our equivalent, ATLS or something. I am not a huge proponent of having required specific training where it tells you how much to give at what point. But I do think a standardization of this, and this matches what some conversations with higher up Ukrainian folks have, yielded. I think having that would probably allow for a more uniform survival rate. So you're not lucky or unlucky depending on where you are. And the second thing is, I mean, I've heard of the logistics officer also being in charge of medical. That is the prioritization of medical training and care is something that I always preach, being in our system, in a NATO system or in Ukraine. And I think that is probably what I would say. It's so important because what gets people to fight? Protecting their loved ones and knowing that they'll be taken care of, or their bodies will be taken care of. You drag your body back and get them care. You want to know you drop them off with somebody capable who will take care of them. That is, I think, a key component of military medicine that the country is very much embracing. And I think as everybody can do a little better, you.
Yeah, absolutely. And people in Europe and the U.S., all our allies, if we're not paying attention, we're going to suffer the same fate, because everybody assumes what you've been doing is right. And then, just like Mike Tyson says, everybody has a plan until you get punched in the face. We have our, for example, our soft medics, our course is so long, right? Well, once you start attriting people, especially as rapidly as they are in Ukraine, that training pipeline gets shrunk real quick. And you have to know beforehand what you can trim, or you're going to trim something that was really important, and just for the sake of time. And that's something that I've come to learn anyway in Ukraine. Their medics their training is 5 days long. 5 days, to cram all of medicine in your head is probably unrealistic. So, what do you trim? How far do you take people to actually understand and can master those basics, however many of them there are, so that they can go forward and do good things? How do you prioritize T-TRIC to what you actually really need to know versus I can get this guy farther back to somebody who knows, that next step.
It's such a good point. I think, that's actually, if I were to take it back to a maybe simpler recommendation, I think a huge thing that would make a difference is prioritizing the right basics in the training. If the 5 days is not, let's just say that is the finite amount of resource that can be allocated, and that can't be changed. I do see sometimes a trend towards wanting to get to really advanced topics quickly in these condensed trainings. And I think there's a sense of I've been trained the basics. Now I want to kind of run, walk, run, jump, whatever. And just, hammering hemorrhage control. which we know is the biggest thing for morbidity and mortality, right? It's just hemorrhage control and DCR and those like basics that are not very sexy. But if that can just be hammered over and over again, I think that it could make a difference. And that's something that could make a difference in a short amount of time, which obviously is what we're all trying to do. So yeah, basics.
The medic trying to like ask me to like teach him Berboa when he can't even get an IV. I mean, that is not a single occurrence. That's a great point.
You see that a lot. Yeah.
Yeah. That's just, I think, human nature. You want to always learn the next advanced thing because obviously the more words you know, the better you are. But it's the basics. I've seen the basics save vastly more lives than some advanced procedure. And I think if we could focus on those things, we would see those mortality numbers come down.
Agreed.
Awesome. Any final thoughts?
No, I just would thank again for promoting this conversation. And I think Florian mentioned it earlier, but we have many very awesome Ukrainian colleagues who would, love to come give their perspective if this topic is something you're interested in, and we're always happy to promote that. So.
Yeah. And one more time, I mean, we're here in the luxury of our homes, no air raids going off and everything else. I think everybody listening should not take that for granted, and be smart about preparing and knowing that we're in a very lucky spot right now in the world, and that our friends and allies are fighting the good fight and are being very courageous doing so.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.